we're going to start off with a case. So this is Trevor Tremonti. This is a patient that you're going to see in 17 hallway, just exactly like this. He's clutching his nose and he's saying, doc, my nose has been bleeding for like an hour. Am I going to die? I say yes, slow and painful death. Moving on, these are the objectives. Where the bleeding is coming from, risk factors, management, when you should call ENT and whether or not you should admit these patients. So let's start off with where's the bleed. So going back to anatomy, can anyone tell me where this bleed comes from?
Castleback?
Yes.
Castleback?
Castleback. And I think I heard it. So anterior bleeds are typically going to come from the Castleback plexus, and you're going to see it coming out of venaries. And posterior bleeds, they're going to be coming from the sphenopalatine artery, and sometimes you'll see it going into the posterior pharynx. And that's 90% of the time they're anterior, but 10% of the time they're posterior. And so in terms of risk factors, what are some risk factors for patients that come in with epistaxis?
Dry.
Right.
Project heat.
Good. So you guys got most of them.
Foreign
So
body.
most of the time they're going to be anterior, and it's going to be due to some trauma or irritation, some digital picking, some chronic drug use. Can be allergic rhinitis, can be viral rhinitis, can be dry air, things like that. Can also be foreign body, and you can also get septal perforations too. What are some other risk factors though?
Bleeding disorders.
Right. Great. Good, you guys got some of them. So medications, anticoagulation medications, also steroids. It can thin the mucosa, so we'll pick at it if it bleeds. Also coagulopathies like hemophilia, von Willebrand syndrome, also nasal polyps, neoplasms, things like that, and also Auser-Weber-Rendu, where you get the telangiectasias right here. The other thing that was mentioned is also hypertension. It doesn't necessarily cause epistaxis, but it can prolong it or make it worse. In terms of the disease presentation, it's very bimodal. Usually happens in kids younger than 10 or people between 45 and 65. And it's typically men and also underlying causes like coagulopathies. So going back to the case, you see this guy, he's got normal vitals, and you start off with your evaluation, right? So what are you going to do? You're going to look, right? So look at his nose, you're going to use a good light source. I guess some institutions have nasal speculums. I don't think that we have them at ours. No, okay. And you're going to be looking for the bleeding source, you're going to be looking for any masses, you're going to be looking for trauma, ulcerations, erosions, things like that. And then in terms of management, what is the first thing you want to make sure you do? Really all for patients.
ABCs.
Right, so ABCs. So you want to take into account your ABCs, have your airway cart there, if not, at least know where it is. You also want to have good suction available, and also, again, a good light source. In terms of stopping the bleeding, you want to start with in a stepwise fashion. So you're going to start with, so we're going to talk about anterior first, because that's where most of them come from. And you're going to do direct pressure. And you're going to have a patient go in a sipping position, like Trevor's showing us here. You're going to have them blow their nose to expel the clots that are there, and you're going to use an alpha agonist to sort of vasoconstrict. You can use Afrin. You can also use epinephrine. They've used phenylephrine in the past, but UpToDate has been recommending against it because it's shown intraoperative death. I'm not sure how. And then you want to have the patient in a sniffing position. And then you're going to hold direct pressure over the cartilage for like 10 minutes. And you're going to recheck them. And if the bleeding has stopped, you're going to just observe them for like 30 to 60 minutes. And if they don't rebleed, then you just send them home. And if they're still bleeding after that, you want to consider cautery. Cautery is, they use silver nitrate. I haven't heard anybody use this recently. They still do? Oh, I know we do have it, but do we use it?
I have.
Oh, okay.
If you see a visible vessel and it's not stopping with aspirin and pressure, sometimes it's hard to find an actual spot to organize.
Yeah.
So,
There's a lot of blood in there. You can't just stick it.
Yeah.
Some nitrate going around.
so the other thing was, when I was reading about it, you can't apply the silver nitrate to a bleeding surface.
Right.
You have to have some sort of hemostasis before you do put it on. So you want to do that alpha agonist and the direct pressure to hopefully get it under control before you apply the silver nitrate. The other thing is you don't want to put it on both sides because it can cause perforation, and you also don't want to put it over a large area. Some other things that you can use are Surgicel or gel foam or Avitine. And if that doesn't work, then you want to move on to nasal packing. So there's 3 types of nasal packing here. There's the Maricel, the balloon, and then the rhino rocket. So these each function a little bit differently. First, you want to pre-treat patients with some alpha agonist, and then you want to use one of these. For the Maricel tampon, it expands when it's wet. So you want to wet it a little bit and then put it in. And then when you put it in, you don't want to angle it up. You want to angle it straight back just above the hard palate because you want it to be inferior to the inferior turbinate, like here. For the packing balloon, you want to inflate the, so this is the anterior and this is the posterior. So you want to put it all the way back and then slowly inflate it. You want to also read the instructions because the balloon can be different sizes. So you don't want to inflate them all the way, you just want to inflate it enough to cause tamponade. And you can use saline or water with these. For the rhino rocket, the way that you use it, you soak it for 30 seconds in water, and then you would inflate it with air only. And do not put any sort of no bacitracin, nothing on it, because it actually messes up the material, and it makes it ineffective. And with all of these, besides the rhino rocket, you can put bacitracin on it to prevent toxic shocks. And then you're going to leave these in for 2 to 3 days and have them follow up with ENT or come back to the ED. So this is where the nasal packing should be. And if they continue to bleed, then you want to think of posterior. So with posterior, you can use the balloon packing, and you can also use a full lead catheter. So you want to inflate it, and you want it to have it positioned in the posterior choana, and have it stay there. Because if it moves forward, then it's not effective for posterior bleed. And then what about TXA? So in terms of TXA, there's been a Cochrane review that showed there's a statistical reduction in blood transfusion. There's also 70% of normal patients stop bleeding in the TXA group. And also it's been shown for this same 70, also 70% in the patients who are on aspirin or Plavix. And I was also listening on MRAP that you can do a concoction of Afrin, lidocaine with epi, and also TXA. Soak a piece of gauze in it, and then twist it up, put it in the patient's nose, have it sit there for 30 to 40 minutes, pull it out and recheck. You'll see the bleeding stop. You do use 500 to 1,000 milligrams of TXA. And so what if you're still bleeding? Then you want to consider calling ENT because you might have to do some sort of ligation or embolization. There also might be coagulopathy playing into it. And some other things to consider are complications that can go along with this. You can have adhesions, you can have necrosis, you can have aspiration, MI, hypovolemia. You can also have a risk of infection. They talk about a lot toxic shock syndrome. And also it's the rebleeding. And then with posterior packing, you can have vagal stimulation, which can cause dysrhythmia and bronchoconstriction. So in terms of dispo, if a patient is on warfarin and they're in a therapeutic range, they can continue the warfarin. But if they're taking NSAIDs, you want to tell them to stop for at least 3 to 4 days. In terms of antibiotics, you would give them Augmentin. If they're allergic, you give them like a second generation cephalosporin. But the evidence behind antibiotics isn't great. Just ENT tends to give it. And you want them to follow up with ENT or the ED in the next 2 to 3 days, they could be packing in. In terms of admitting, you would admit patients who have bilateral packing if there's severe anemia, if they're requiring any sort of transfusion, if they have posterior packing because of that risk of vagal stimulation and dysrhythmia and bronchoconstriction, so you want to admit them to the telephone. So in summary, epistaxis, anterior versus posterior, you want to consider the risk factors. Think about the stepwise management, and when you're admitting, especially for posterior packing, you want to admit to tele. Those are my sources. Any questions? Yes, he approved.
Did he post all these on Facebook?
Yes.
So he did this himself?
It's his own fault.
I just want to make sure. I want to clear that up. Secondly, I think my personal approach to epistaxis, I'll do everything I can to not pack somebody's nose. So that's quality pressure. I think a lot of times we forget about the pressure will actually do the job most of the time. You're going to definitely have cases where all the pressure in the world is not going to do it, but I find that if you have quality pressure, and sometimes you can have the patient, but the patients a lot of times don't do it right. You can try to teach them, but some patients you're just not going to teach them how to do it right. And it involves somebody standing there holding pressure for more than 30 seconds, like, standing there for a while, holding good quality pressure and doing it. And then trying all sorts I'll do pressure, I'll do the Afrin or neosynephrine. I didn't know that you can get deaths associated with that, but
Yeah, I didn't know you.
I think it's a nasal spray that I'm pretty sure, is it over the counter? I don't know. Afrin is for sure over the counter. But they have it, you have to get it from the pharmacy, so while you're holding pressure, you order the Afrin, do it all at the same time. And then I'll look in. If I see something that looked like it might have bled, then I'll take the silver nitrate and I'll cauterize it and hope that that's enough. And I think my next step is TXN. And then packing.
One thing that I love when I had a patient probably is obviously what I didn't know is that it's really important to tell them not to blow their nose because they'll blow out the clot and then they'll just restart bleeding. So whenever tell them if they have that sensation and they need to blow their nose to not blow it out, you can just do all these measures to form the clot. Otherwise they just blow the clot out and you have to.
Yeah, I think it's a good discharge instructions are
I didn't
really
know
important
that.
for these patients.
Not blow their nose.
You can teach them how to do hemostasis at home before they come back to the.
You can also use like tongue depressors and tape one end and then it just squeezes really tight.
I don't know. I would not recommend it. No, I know.
I've tried it.
Hate the patient's nose.
So
Yeah.
I related this. I was on my EMS rotation, and we had a guy on blood thinners who had epistaxis who we got called to his house for, and I held pressure in 15-minute intervals 5 times, because I was not taking a guy with like a tiny trickle to the ER for epistaxis, and it took 3 to 4 sessions of 15 minutes of solid me holding pressure for him before it stopped, and then so you do have to do it for a lot of time. Sometimes it can be really time consuming. So teaching patients not to just do it for 15 minutes and then go to the ER, but to do it for 15 minutes, check, do it for another 15 minutes, check, do it for another 15. They should do that like 4 to 5 times before they consider coming to the ER, unless it's hemorrhaging and they're spitting out clots while they're doing it. It takes multiple rounds.
With regards to applying the TXA or whatever we're putting on that gauze that you mentioned, MRAP says that they snake in there. Do you put it on gauze, put it in the nostril, and then again apply pressure?
That's what I do. I'll pack that really tight and then I'll hold my pressure with it, so that way it's really actually adherent to the mucosa there. And I have pretty good success with that. It doesn't always work though, but I usually start with that.
So is there any concern for like dry debridement, kind of like when you pull out the gauze, like ripping out a clot?
Yes, so that's why I only do it right. Like if I'm going to put anything in the nose, I make sure that it's soaked with something. So usually nowadays it's TXA. So I'm just going to hold it for a few minutes, I know I've wet TXA, and then I can slowly pull it out so it doesn't rip the clot out. That's why the Miracell is the most uncomfortable type of packing, it seems like, for patients. And especially because once you pull it out later, a day or two later, they haven't completely healed. That packing is already now deflated inside the nose. It's not like a rhinorack where you deflate a balloon or other things like that. You're going to have to pull that whole thing out from the nose, and it's going to scrape everything out. So that in particular I find is not my favorite type of packing, but that's what we have here actually.
I've never had nasal packing. I cannot imagine it's comfortable. It doesn't look comfortable at all, which is why I would spend hours with these patients before I pack them to try to avoid it. It just looks really uncomfortable. I mean, stick a tampon up your nose and see how it feels.
I mean, that's the thing they complain about most, right? It's all the patient complains about how uncomfortable it is.
Yeah.
And then the other thing they do is they like start gurgling and snorting and trying to like spit out all the stuff, and that just clogs the clot anyway. So.
Good luck.
I don't know how to make sure that it's not. Good morning, everybody. Okay, so today I'm going to talk about traumatic dental injuries. I personally think the mouth is absolutely disgusting and could have never gone into dentistry, but I have so much respect for those who have. I think that teeth in the emergency department are things that maybe we don't think about needing to deal with right now because we are at an academic institution that has an OMFS, and we do have like a dental clinic that we send people to. But when a lot of us leave this place, we'll be going into the community where there is not necessarily a dentist on call and maybe not an OMFS service in your hospital. And very interestingly, there's, in terms of the research, there is kind of a need for increased training in dental emergencies among emergency medicine physicians. And at least 2% of all visits to the emergency department every year are for dental-related emergencies. That's somebody getting this too. Yes, so 1 in 3 people during their lifetime will have some kind of traumatic dental injury. The majority of people will experience these traumatic dental injuries when they are children, before the age of 4 years old, because kids are not very smart and they bump into things. For the sake of today's presentation, I'm only going to be talking about adult dental injuries. As you've probably maybe been presented to before in medical school, pediatric teeth are different, and a lot of times we don't do anything when they fall out or get loose. Yes, I've already mentioned these things. So there are 5 major traumatic dental injuries that we will encounter. Dental fracture, dental subluxation, luxation, intrusion, and avulsion. Before we start talking about those, sorry, my slides are going to become really, really bright in a second. It's important to kind of remember the anatomy. When you do call a dentist or you do make a referral, they might ask you which teeth you're talking about, and kind of just brushing up with your incisors, canines, molars can be very helpful. The most commonly injured teeth are the ones that are kind of the most prominent on your face. 8 and 9, the central incisors on the top, are the most commonly injured. And then right after that, the 2 surrounding, and then after that, the 4 on the bottom and the front. With regards to dental trauma, we have to think about the things that we don't want to be exposed. The pulp is where your tooth's blood supply is. The dentin is extremely important as well, and the enamel is kind of what we see on people's teeth. Moving forward, we're going to be talking about how to kind of prevent injury and access of the things that are normally disgusting and in your mouth, access of those things into the pulp. Okay, so we're going to start with dental fractures. Dental fractures are divided into 3 classes called Ellis classes. Ellis class 1 is the most common type of dental fracture. It is also the best case scenario. If we were going back to that kind of tooth picture that I showed you that had all the dentin, the pulp, everything labeled, you'll see that this only penetrates the enamel. So you don't have access to your dentin or your pulp where the blood supply is. In these cases, for the most part, you don't really need to do anything. The patient might have some kind of like cold or heat sensitivity, but this can be managed non-emergently by a dentist. Just say see your dentist in the next week. We don't really care about this. LS2 goes through the enamel and the dentin. This is a little bit more serious. The tooth will be sensitive to temperature and palpation. In these situations, we want to do a good job of cleaning the tooth with normal saline, and then actually drying the exposed dentin and covering it with some kind of like cement platform. There are a few things that I'm not sure which ones we have access to, but calcium hydroxide is typically what we use to kind of paint the tooth. Dical is a common brand. There's another brand called Prelene. I'm really not sure what we have, but I imagine that we have access to at least a couple of these.
It's calcium hydroxide.
Yeah. And it doesn't need to be pretty. We're basically just coating the tooth so that we have a layer that protects what's supposed to be inside of the enamel from the disgusting things in your mouth. An Ellis class 3 goes through not only the enamel and the dentin, but it also penetrates into the pulp. And this is where we start risking the blood supply to the tooth. And when you think about somebody who has a dead tooth, that nasty kind of like green, blue-looking tooth in the front of their mouth, this is why, because the pulp has been accessed by the contents of the mouth. This is a true dental emergency. We want these people to see a dentist as quickly as they can. If this person is in your emergency room, you want to consult your dental clinic, or I guess even OMFS, they might be mad at you. But if you are in the community and you're in a community where the dentist only works from 10 a.m. to 4 p.m., because that's what they do in most places, you treat this like an LS2 fracture and you clean it, dry it, and cover it with the calcium hydroxide. Have them follow up with the dentist as soon as they can. The worst case scenario, you get pulp necrosis and you get this kind of dead looking tooth. The blood supply has been compromised and the tooth is not receiving nourishment. So I just touched on this calcium hydroxide. With most of the dental products that create like a cement or composite, it comes in 2 tubes. I don't know if anybody's ever like used a hair dye at home, but usually you have like the dye and then the accelerator. This is kind of similar. You have the base and the catalyst. So with all of these things, you'll use basically 50 and 50%. With the calcium hydroxide, it gets sticky and hard fast. You don't necessarily want this on you unless you feel like waxing yourself. It dries fast, so you're going to put this onto something where you can mix the 2 components of the base and the catalyst. You can use a cotton swab and just gently apply a layer to the exposed part of the tooth, and it'll dry within 10 minutes. You can have them bite down on gauze afterwards. Moving on to subluxation and luxation. So subluxation, so you get hit in the face by a fist or a baseball, and you feel like your tooth is wiggly, but when you get to the hospital, it doesn't look like it's actually displaced. So it's not twisted, it's not kind of more out, and it's not kind of more in. You don't have to do anything with these patients. You might see that they have like a rim of bleeding around the tooth, or that the tooth's in a lot of pain, but you don't want to push this, you don't want to pull this. This could quickly turn from a subluxation into a luxation. You just want to advise the patient to kind of leave their mouth alone, and soft foods, follow up with the dentist in the next week. It can be pretty painful. So luxation, the tooth is not only loose, but it's also displaced. This may or may not involve some component of fracture to the alveolar bone, which is holding your teeth, and often involves injury to the periodontal ligament, which is kind of like holding the tooth in that bone. It's kind of difficult for us to evaluate these patients to the extent that they get evaluated in a dental office, because we don't have those panoramic x-rays. If you really, really feel like a patient needs an x-ray because you're concerned the trauma has broken some component of maybe they're even, maxilla and the alveolar bone, I would actually, based on what I've seen, recommend getting an x-ray. So with these luxations, you should try to reposition the tooth very gently. You could potentially keep this person from having to get a fake tooth implanted or compromising the blood supply of their tooth by quickly repositioning this tooth back into place. Once you do push this tooth back into place, we get to another kind of dental cement. This is a dental splint. One of the brands that I saw come up a lot in my research was Copac. This is kind of like a putty. You're going to do the exact same thing where you have to mix a base and a catalyst together and kind of like roll it between your fingers. Because this becomes really sticky, in this case, since you are rolling it between your fingers, you're going to want to put something on your gloves first, like a lubricant or something similar. These work best when you put them on both sides of the teeth, so you kind of make a little cradle for the row of teeth that have been damaged and make sure that it's sticking onto a tooth that has not been luxed. Okay. Intrusion involves a tooth getting pushed too far up into its little alveolar cradle. If it's been pushed less than 3 millimeters, do nothing. If it's been pushed more, gently pull the tooth out. And again, use the disc board or whatever you have to kind of form that putty cradle. If you don't have any of these things, you can actually use aluminum foil and just kind of make a splint. Okay, avulsion, your tooth has come out. Things that you want to know when this patient has come in: how long has the tooth been out, time is tooth. For every minute that your tooth has been out of its socket, this has been shown to decrease the viability of this tooth by 1%. Really important to try to replace the tooth back into the socket within the first 1 or 2 hours. Also, where is the tooth? Does the person know where the tooth is? Did it fall out onto the ground? Did it go missing, and could it be in their right main stem? Could it be in their lip? If you are worried about this being an aspiration event, get an x-ray. And in terms of storage medium, I know we've talked a lot, or maybe we've heard people saying if your tooth comes out, leave it in your mouth. This can be really dangerous. You can aspirate your tooth if you leave it in your mouth. Studies have shown that, in terms of comparing the Hank's balanced salt solution and the normal saline and leaving it in your mouth, and milk is just as good, if not better, than all the other things. So put your tooth in there. Okay. If you do not have, just making use of all the things that we can. If we don't have a Copac and we don't have aluminum foil, but we have an N95 mask, we can cut the metal off of the N95 mask and use some Dermabond to put it on the tooth and hold it in place as a splint. Okay. And these require kind of urgent OMFS follow-ups, just as soon as the patient can get there. Within 24 hours is the desire. And that's where resources. Any questions?
Quick question.
Yes.
For dental fractures, Is there any change of management for like time frame? Like obviously if the patient comes in emergently, you can put on the counseling process. But what if it's like 5-6 days out, or you see somebody they have protoclinic who's exposed to home?
Yeah, so that becomes kind of like at that point you're not saving the home. But if your patient is a poor story and you're like, this could have been yesterday, this could have been 6 days from now, I would say just cover it. But if it's truly been 6 days, I would say just follow your dentist in 3. But I need to do a little bit more research on that myself.
Dr. Watson, there we go. Hello everyone, my name is Julian Watson. I'm a rising PGY2. So I have 9-ish minutes to do this. I'm going to do my best. So I'm going to talk to you about myasthenic crisis. Real quickly, can we just quickly go through this 15, 25, and 45-year-old and think about what they have in common?
You're breathing fast.
Okay. What was that?
We all have myasthenia.
Good job. Okay. All right. In fact, what they all have in common is they all want you to think they have myasthenic crisis. Okay. The first guy, 15-year-old, actually has a peritonsillar abscess. The second one is an SVT, and the third one is actually having a stroke. So the whole point of this is basically to get into my first objective for this talk, which is to just, if you have a patient who has a history of myasthenia gravis, don't anchor on myasthenic crisis. It can present as multiple different things, multiple chief complaints, but keep a wide differential. The second thing is look more at the patient, look less at the patient's PFTs. We'll get into that. And the third is focus on decreasing the work of breathing in the ED. The last is if you do end up intubating these patients, just be mindful of your medications. So quick refresher, myasthenia gravis, it's most common neuromuscular disease that we're aware of. In women, it peaks in their 3rd decade. In men, the incidence peaks in their 6th decade of life. Basically, this is autoimmune, right? We all know about this. Antibodies basically attach to the acetylcholine receptor. And it does 2 things. It prevents transmission from acetylcholine to the muscle, and it actually causes complement-mediated destruction of those receptors. So you lose receptors as time goes away, as time moves. What does this mean for the patient? Basically, they wake up in the morning, they're the strongest they're going to be for the day usually. It's going to get worse as the day goes on. It improves with rest. It worsens with repetitive activity. Now, what is the definition of myasthenic crisis? Basically, this is any worsening of myasthenia gravis that causes respiratory failure or threatens to cause respiratory failure. This is usually triggered by something, and that's really important for us to keep in mind. It could be pain, it could actually be emotional stress, it could be infections, other disease processes, and often it could be medications that can trigger a crisis. So presentation, how do these present? This is pretty much perfect. There's a lot of bulbar involvement. Diplopia is a common one, ophthalmoplegia, dysphagia. Patients tend to drool a lot. They have a hard time lifting their head up off the bed. It's important to recognize that this could involve proximal muscles. It could eventually lead to the diaphragm as well. It only has skeletal muscle involvement, so you're going to have intact sensation. Your pupillary reflex is going to be intact. Deep tendon reflex is going to be fine. So just keep all those in mind. Differential. So the easy choice for your differential in these patients is to recognize that they have a history of myasthenia gravis and then find a way to make that fit the chief complaint, which a lot of times it can. The harder choice, and the choice I'm going to vouch for, is to think outside the box. Forget that they have myasthenia gravis temporarily. Create a differential for their chief complaint and go through that differential. This has 2 things that it basically benefits you. Basically, first, it gives you a peace of mind, right? If you create a differential for this chief complaint and you cross everything off, you can have peace of mind that you're not really missing anything and you can go forward as treating this as myasthenic crisis. The second thing is I just talked about, we know that a crisis is oftentimes triggered by something else, right? So if you go through differential and you end up finding that this patient actually has a pneumonia or an arrhythmia or something like that, and you treat that, you now potentially just treated the trigger, which can now decrease the severity of this crisis and decrease the length of this crisis. Evaluation. Obviously, as with any patient, you go through your ABCs. Airway, is it patent? Are they talking? Are they muffled? Are they drooling? Breath sounds, are they equal? They're normal. Circulation, vitals, all those sorts of things. Really importantly, though, you want to look at this patient's work of breathing. You want to pay attention to, are they, retracting? Are they using accessory muscle use? Are they gasping for air? Are they lethargic? Do they look altered? Ask the people at the bedside, the people that know them, do they seem like they're themselves? Other things you want to do is you want to send some labs, because again, this is a clinical diagnosis primarily, but you do want to look for a trigger. You want to look for electrolyte abnormalities, including MAG and FOS. You want to look for metabolic abnormalities, including like TFTs, lipase, that sort of stuff. And you really want to look into a medication history, because this is important, because if the patient recently started another medication that put them into crisis, it's important for you to know, but it's also important for the patient to know. Because if we spend all this time fixing them in the hospital, and then they go home and they take that medication again, they're going to come right back. A couple quick tests for when you're suspecting somebody's in a myasthenic crisis. This is the single breath count test. This is very quick and dirty. You ask the patient basically to take one deep breath, have them count as high as they can. If we all did this right now, we could probably get to like 30, 50 relatively easily without taking an additional breath. If a patient can't get to 20, that's concerning. Okay? If the patient can't get to 10, that's very concerning. Basically, the lower the patient gets without having to take an additional breath, the higher your concern for this patient should be. The quicker you should move, the faster you should get other people involved, things at the bedside, airway equipment, all that stuff. Next thing is PFTs. These are more for your consultants, okay? And I'll talk about that in a bit. The first one is your vital capacity. This is just asking the patient to take as deep of a breath as possible and then exhale all of that. And you're just looking to see how much volume of air was involved in that. Normal is above 60 milliliters per kilogram. If they can't get at least 20 milliliters per kilogram, that's worrisome. Okay. The next one is the NIF, also known as stands for the negative inspiratory force. Basically, the patient inhales through a tube that's attached to a meter, just like that one, and you are measuring the amount of pressure, negative pressure, that's generated from their inhalation. If normally, like all of us can probably get to about 60 centimeters of water worth of negative pressure. If you can't get to at least 30 centimeters of water worth of negative pressure, then that is said to be concerning as well. Now, the issue with these PFTs, they're very effort and position dependent. All right, we've all done like peak flow on people, asthmatics, and we see how the patient needs to actually cooperate with you in order to get actual value that you want to trust. If they're not cooperating with you, the values that you get from these PFTs are not worth making decisions on. The next is if the patient is supine versus sitting up, that's going to actually change how the value is. If they're supine, they're no longer having gravity helping to pull down abdominal organs away from that diaphragm. That diaphragm's not going to have as much room to move and do its thing. The second thing is the supporting studies for these PFTs are actually pretty questionable. They're older, they're retrospective, there's no actual sensitivities or specificities that were extracted from these studies. And the kicker is they were actually done in Guillain-Barré patients. And it's a completely different disease process at the end of the day. We know that myasthenia gravis is improved with rest. It's worsened with repetitive muscular activity, much like, asking a patient to take a deep breath repeatedly. So that, you need to think about that. The other thing is the NIF, even in these studies, were really the more variable of the two, between NIF and vital capacity. And it actually never added any additional information when compared to the vital capacity. So basically anything that the NIF found in terms of like risk factors for respiratory failure, the vital capacity found it more often and more consistently. So it's like, why are we doing the NIF in the first place? But the consultants want it, so gotta get it at this point. So in the ED, how are we treating these patients? So textbooks are going to say like acetylcholinesterase inhibitors, pyridoxastigamine, neostigmine. In the acute care of these patients, we actually want to avoid those because they cause increased secretions in the airway, which is like not ideal for a patient with a potentially compromised airway. Things like corticosteroids, actually in the chart that I showed earlier, we know that to be a trigger for a crisis, so we don't want to give that either. Ultimately, any medications that we give are, if at all, are going to be in conjunction with a consultant. You're usually going to have to give them IVIG or Plex after they're admitted. So in the ED, what we're focused on is basically manipulating this balance. We know that they're getting weaker, right? So what we're trying to avoid is we basically want to decrease their work of breathing so that we can help their respiratory muscles. We don't want them to give out, and we don't want to intubate them. Okay. If we intubate these people, they're known to be tough to extubate. They have longer ICU stays, therefore they're more prone to complications. So how do we do that? Well, quickly, first of all, we don't want to exert them more than we have to. For example, by making them do PFTs unnecessarily and continually. Second is we want to have a very low threshold to start things like high flow nasal cannula and BiPAP. Those are shown to actually prevent intubation, which we know with people like with APE, it helps work of breathing. So we want to do that stuff pretty quickly. All right, but if at the end of the day, the patient's tanking and you have to intubate, you have to intubate. But if you do, just two things I want you guys to keep in mind. The first is less rock, more sucks. We know that succinylcholine works by binding to acetylcholine receptors and causing a massive contraction of the muscles. These patients have fewer acetylcholine receptors, so you need to give more succinylcholine. The dose is typically like 1.5 to 2 times more. Rocuronium and other non-depolarizing drugs, they work by just binding to the acetylcholine receptor and just blocking acetylcholine from doing its thing. Since there's less receptors available, you can give less drug. So typically the dose is like half. And the second thing is that either one you decide to go through, just know that the paralysis is going to be stronger. It's going to be typically like 2 to 4 times longer in these patients. So you need to be aware that your sedative is going to wear off faster than your paralysis is most times. Okay. In summary, patients with myasthenia gravis, don't anchor on myasthenia crisis. Keep a wide differential. Second thing, look more at the patient, less at the PFTs. In the ED, focus on the work of breathing. And if you do intubate, just be mindful of your medications. That's it. Any questions?
I got a question. How does it affect your management of PFTs? What do you use it for?
So they say that basically you should have a higher threshold or lower threshold to intubate in these patients. What if they have like lower than 20 or lower than 30 respectively?
Exactly. Under 30 is
Maybe not intubate, but use some other measures.
use some other techniques.
Yeah.
Or like BiPAP first. BiPAP is the first thing you should do before obviously. You are right. It is very tough to extubate these patients.
Yeah.
And when you have to do it. But if you have earlier BiPAP, it prevents it from teeing out earlier.
I use it to identify them and risk stratify.
Yeah.
So yeah, NICU versus for the patient who comes in with maybe some symptoms that doesn't be really subtle and early on, you do the NIF and it's like totally normal, they're like maybe there's something else going on, right? Because you don't want to just say, oh, this is myasthenia, it's always myasthenia. But if their NIF is totally normal, you're probably not going to go down the BiPAP. You're going to be more cautious with this person, but it will help me identify whether or not they're really something they need to get over. I mean, NICU for how urgent and whether or not ready for BiPAP.
One more question. How do you treat someone who's got an asthma exacerbation who's got myasthenia?
That's a good question.
Axel?
I don't know. I've had a couple of these.
I think I would do the same.
They still need the steroids.
You still give the
Start by
steroids.
that.
Yeah, I think I would do the exact same. I would give it steroids.
If you're having real bronchospasm, you give the steroids, and then you swap the area. You have to give
A lot of times the patient gets steroids. Just for the maximum.
Yeah, pulse dose, right? Doses.
And then just don't forget just a general.
You don't see it.
Don't forget
Yeah,
diaphragmatic
feel free to
dysfunction as any cause of shortness of breath, right? If you're doing a shortness of breath workup on a patient, and you're going through your list of all the different etiologies, what it could be, a lot of times if you don't find an answer, it's because we didn't also think about some type of diaphragmatic injury, from whatever it is, myasthenia, Guillain-Barré, they had recent scaling block for surgery and it caused front nerve paralysis or something like that. Just keep that in your differential as well, just for a differentiation.
How do you measure the vital capacity?
Because you basically bring respiratory
Yeah, our
down.
respiratory therapists come down with both of these. So a lot of times you're getting the vital capacity and the hip at the same time. So you just call respiratory therapy if you want to get those, and they just do it right there.
Yeah. They come down with 2 different meters and they just do it right there.
Those are the easiest ones to get. You know, you don't need a lot of complicated machines to get it.
There's this, there's actually that's like this disposable one. And you just check them in. It's a little plastic thing.